Today we are going to discuss about cognitive behavioral therapy for insomnia, part 2 video. In this video, I'll be discussing about the effectiveness of CBT for insomnia. In the part 1, I discussed about various components of CBT for insomnia. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about the effectiveness of cognitive behavioral therapy for insomnia. What are the measures used to measure the effectiveness, that is subjective versus objective measures, comparing standard CBT-I versus app-based CBT-I, and also I'll be touching upon stepped care CBT-I for insomnia treatment. Insomnia is associated with substantial impairment in quality of life, loss of functioning, economical decline, and increased health risk. The increased health risk is for both mental health and also physical health. With regard to physical health, it can be diabetes, hypertension, and at times, because of decreased sleep, accident can occur and they can be dangerous to other public also. Insomnia is characterized by perceived difficulty in initiating or maintaining sleep or early morning awakening, which has a serious consequences in day-to-day functioning. If you look at the prevalence of insomnia, it varies from 30% to 6% based upon the population studied. Are we looking for acute insomnia, chronic insomnia? Which population is studied? Is it a disaster-affected zone, rural or urban population? However, based upon the population, the diagnostic criteria used, and caseness, the prevalence varies from 66% to 30%. If you look at the acute insomnia, which is less than 1 month, 1 in 3 suffer from acute insomnia at any given point of time cross-sectionally. If you look at the senior citizens above the age of 65, 75% of them have insomnia. If you look at the adolescents or preteens, 43% have acute insomnia. With regard to chronic insomnia, it is 1 in 10. That is 10% of the population has chronic insomnia. What about in India? The studies have looked into insomnia in India. It was found to be 25%. Obstructive sleep apnea is around 37%. Restless leg syndrome, 10%. That means it is prevalent even in India. If it is so prevalent, what is the treatment? If you look at the various guidelines, in the ideal world, it is cognitive behavioral therapy for insomnia. Unfortunately, the access for cognitive behavioral therapy for insomnia is very limited, not only in India, even in US, UK, and other developed world. In US, the waiting period is somewhere around 3 to 6 months to get therapy. Unfortunately, in India, we have very few trained psychotherapists for cognitive behavioral therapy for insomnia. We do not have more than 3,000 cognitive behavioral therapy for insomnia trained specialists. If you look at the 10% of our population, means 15 crore population require CBT-I. That means, being the first line of treatment, can this 3,000 psychotherapists, can they deliver? It is simply very difficult. In such a scenario, across the world, the default treatment becomes the sleeping pills, that is benzodiazepines. Unfortunately, the irrational use of benzodiazepine has become very common. Use, overuse, and misuse of benzodiazepine is been a trend not only in developed countries but also in developing countries. Many general practitioners, primary care doctors, nurses, pharmacists are not trained in sleep medicine, insomnia or in cognitive behavioral therapy. If you look at the other end, even the psychotherapists are not trained in cognitive behavioral therapy for insomnia. Since there is a poor access for cognitive behavioral therapy, there is a widespread use of sleeping pills, that is benzodiazepine. This has contributed a dual public health crisis. Of course, insomnia itself and its effects. This use, overuse and misuse of benzodiazepine is causing dependence and another public health crisis. In this background, it becomes very important. We need to exponentially increase the usage and access of cognitive behavioral therapy for insomnia. Is it the benzodiazepine has been misused? In this regard, Most and his colleagues did a study in 2019. This publication was published in Psychiatric Services, and the title is Benzodiazepine Use and Misuse Among Adults in United States. They have termed it as a public health crisis. This study looked into a cross-sectional survey of analysis of benzodiazepine use between 2015 and 16. It was a national survey on drug use and health data. The numbers were mind-boggling. All adults the numbers were 86,186 were surveyed. In that, 10,290 reported of using benzodiazepine. This was the measure of past year prescription with regard to benzodiazepine, use and misuse, substance use, mental illness, and other demographic profiles were compared. The results showed that 31 million adults, that is 13%, reported past year using benzodiazepine. In that, 25 million, that is 10%, were prescribed. 6 million were misusing the benzodiazepine, that is around 3%. If you look at the age and the benzodiazepine usage, adult in the age between 50 to 64 had a highest prescription on benzodiazepine, that is 13%. The age between 18 to 25 had the highest misuse of benzodiazepine. More than 65 years, it was a lowest usage, 0.6%, and it was a prescribed. Unfortunately, benzodiazepine misuse and comorbid use of opioid goes hand in hand. This causes a great concern to any public health personnel. Geriatric use of benzodiazepine leading to dizziness, fall causing femur fractures and other fracture is also a great concern in geriatric age. All these factors, as indicated, cognitive behavioral therapy as the first line of treatment for insomnia. But unfortunately, access to treatment by psychotherapists is very limited across the country and also across the globe. Now let's look into the effectiveness of cognitive behavioral therapy for insomnia. An important article published in Faculty Opinion by Munich and his colleague. The title of the study is We Know CBT-I Works. Now what? This was a very interesting article. If you want to know more about this article, please download this article by scanning this QR code. This study clearly said that CBT-I is as effective as hypnotics, that is sleeping pills. That means in acute treatment, cognitive behavioral therapy was equally effective as sleeping pills like benzodiazepine. But in long term, CBT-I scored over the medication. Hence, if you look at any of the treatment guidelines, either American College of Physicians, European Sleep Research, Australian Sleep Association, and various other associations clearly say that cognitive behavioral therapy should be the first line of treatment for insomnia. What about the long-term effect of CBT-I? Is it very effective or it weans off? The durability of CBT-I was studied. They looked into the long-term randomized control trial of CBT-I. It was found that subjective sleep latency and wake after sleep onset effects continues to be there even after 2 years. That means once they have received 6 to 8 sessions of CBTI, the effect was there even for 2 years. This is to say that clinical gains maintained over years. Interestingly, the total sleep time continues to gain over a period of time. That means 12 minutes increase occurred every 3 months, 6 months, 12 months, and 24 months. Approximately 50 minutes gain was seen after CBTI was stopped. This clearly indicated the CBTI has a long-term effect and it was better than medication in terms of long-term effects. What about the real-life scenario? This is the many scientists, clinicians criticize that in insomnia research, we take ideal patients without any comorbid condition, and those findings are not applicable in real life scenario like in clinics. Hence, considering this, there were few studies which looked into effect of CBTI in sleep clinics with patient having comorbidity. Again, in real life scenario, at least 4 sessions of CBTI was given. Those studies were reviewed. And the meta-analysis said clearly 23 minutes decrease in sleep latency, 39 minutes decrease in sleep fragmentation, and 20 minutes increase in total sleep time. That means even in real life scenario, CBTI works. What about the effect of CBTI in secondary insomnia? Again, if you looked at various other European guidelines and also various published guidelines clearly said that yes, CBTI works both in primary insomnia and also secondary insomnia. In the past 2 decades, RCTs involving secondary insomnia such as depression, bipolar disorder, PTSD, GAD, schizophrenia, cancer, heart failure, chronic pain, Alzheimer's, multiple sclerosis, alcoholism, COPD, obstructive sleep apnea, period limb movement disorder. In all these disorders who had insomnia, CBTI was very effective. That means CBTI works both in primary insomnia and also secondary insomnia. Let me discuss a simple example. A patient who has migraine attacks repeatedly, recurrent attacks, also has insomnia as a comorbid condition. In this scenario, should we treat only migraine or else treat only insomnia? The treatment guidelines and researchers clearly say that we need to treat both. We need to treat migraine and also insomnia simultaneously with CBTI. For migraine, choose medication. For insomnia, please choose CBTI. When we combine both, the improvement is remarkable in migraine. Hence, my dear friends, in secondary insomnia, please choose CBTI and treat the primary with medication or any other modality. What about the effectiveness of CBTI across age group? Again, studies clearly said that CBTI is very effective across the lifespan. It is effective in adolescents, adults, and senior citizens. That means it can be used both from children to geriatric age. What about the number of sessions required in CBTI? As I mentioned in the previous video, that is in part 1, 6 sessions is more than enough. 2 booster sessions can be considered. That means 6 to 8 is the maximum number. However, there are certain studies which looked into 2 face-to-face CBTI session and 2 telephone calls or telemedicine-based sessions. They were almost equivalent to face-to-face CBTI. In acute insomnia, even one session is more than equivalent to benzodiazepine has been told in a couple of studies. Let's look into CBT-I and outcome measures. CBT-I has clearly 6 different components. 5 components are very specific to sleep, starting with sleep hygiene, stimulus control, sleep restriction, relaxation, cognitive therapy, and wrap up, or you can call it as also relapse prevention. In this regard, if you see, the effectiveness can be measured in various ways. One is normal sleep, if you can see, and difficulty in falling asleep. The red indicates he has at least 2 hours latency period before he falls asleep. That is sleep latency, we can call. Fragmentation of sleeps or break in sleep. You can see there are many breaks which occurs in sleep. And the final one is early morning awakening. So these are the various parameters. Subjectively, the patient is going to say how much sleep latency time is there over a period of 1 week or 1 month, how much is the total sleep time, how many hours break of sleep occurs. So these are the parameters used. Sleep onset latency measured in minutes. Normal is between 15 to 20 minutes. If it is less than 5 minutes, you may have to think narcolepsy. More than 20 minutes, insomnia. That means time taken to fall asleep after going to bed. Wake after sleep onset. Again, it is measured in minutes. The total amount of time spent awake after falling asleep. This is a key indicator of sleep continuity and fragmentation. The normal wake after sleep onset is less than 20 minutes. Mild sleep fragmentation is 20 to 40. Moderate sleep fragmentation is 40 to 60. Anything more than 60 minutes is considered as a severe sleep fragmentation. Total sleep time represents the total nighttime sleep duration in minutes. This excludes sleep latency and nighttime awaking. So that is the time spent exclusively in sleep. That is total time sleep. Finally, the sleep efficiency. This is measured in percentage. The percentage of time spent asleep relative to the total time spent in bed. If a person may spend 10 hours in bed, but actually has slept only 6 hours, here you will be dividing 6 by 10 into 100. That is total sleep time is 6 hours. Time in bed is 10 hours into 100. So that is sleep efficiency. In this regard, there was a study done in Chawar and his colleagues in 2015, published in Annals of Internal Medicine. The title of the study was Cognitive Behavioral Therapy for Chronic Insomnia. This is a systematic review and meta-analysis. Here they included 20 studies which are RCTs and had very good methodological rigor. So let's look into the various parameters. Sleep latency, that is time taken to fall asleep. If you look at the picture, the studies clearly indicated the subjective report of SOL, sleep latency, was improved significantly when compared to control group. If you look at the subjective measures of wake after sleep onset, again measured in minutes, the total amount of time spent awake after initially falling asleep. Again, if you look at the chart, it clearly said that the subjective report of wake time favored cognitive behavioral therapy when compared to control. If you look at the total sleep time, again measured in minutes, represents the total nighttime sleep. That is duration in minutes, excludes time for falling asleep and nighttime awakening. Again, you can see there, majority of the study said that favored CBT-I. However, some of the studies were in favor of control. That means there was no difference. But majority of the studies were in favor of total sleep time. Finally, if you look at the percentage of sleep efficiency that is percentage of time spent asleep relative to the time spent in bed. Again, if you look at the chart, the sleep efficiency again favored cognitive behavioral therapy. All these studies clearly indicated that subjective measures, that the patient said that yes, the sleep latency decreased, the time of awake in between the sleep, that is the sleep fragmentation, decreased, total sleep time increased, sleep efficiency increased. So invariably, the subjective measures were very good. However, on the other hand, another important study by Michel and his colleagues, there they looked into the impact of CBT-I on objective measures, again a systematic review and a meta-analysis. This was a very important study published in 2019. In this study, they looked into the objective measures of polysomnography and actigraphy. Unfortunately, the studies were very few, and the objective measures did not improve after CBT-I, either on polysomnography or in actigraphy. That means the subjective measures improved in CBT-I, objective measures, why it is not improving as significantly as subjective is not known. But however, the patient reported improvement in their quality of life and also efficiency. If you look at the application-based CBT-I, that is apps which are available either on the internet or on mobile phone. Again, on comparing application-based CBT-I versus in-person CBT-I, recently, US FDA approved Sumerist as a prescription app by the psychiatrist or a sleep medicine physician for patients who are having insomnia. And it is considered as a prescribing app for internet digital therapeutics. This is one of the first app which got approval by the FDA when they compared internet-based CBT-I versus face-to-face CBT. 4 meta-analysis clearly said that internet-based CBT-I showed good treatment efficacy. However, the face-to-face CBT had more efficiency than internet CBT-I. That means if you compare to waiting period patients or waiting list patients, did not improve. Internet CBT-I patient improved significantly. More than that, face-to-face CBT-I improved more. So that means if given an opportunity, we have to choose face-to-face CBT-I. If it is not available, you need to choose internet-based CBT-I. Another important study published in 2021 by International Journal of Environmental Research and Public Health by Umaz and his colleagues. The title of the study was a review of digital cognitive behavioral therapy for insomnia. Are they designed for engagement was the important objective they looked into it. They reviewed various apps. It can be Sleepio, Shruti, and Sleep Rate. They looked into whether the presentation style was good, how was the support type, whether there was in-person support was there, human in the loop or completely automated, and the language. Further, CBT-I for Coach, Night Owl, and Mind District. These are the various apps were also compared against each other. If you look at that, all the 6 apps add some of the advantage and some of them had disadvantage. However, the authors concluded, in the absence of face-to-face CBT-I, app-based CBT-I can be considered. What are the advantages? Advantage of digital CBT-I is accessibility, tailored information, advanced algorithms have improved significantly, instant support 24/7, anywhere, any place you can use it, creative communications can be developed, progressive overviews, and over a period of time it can be used n number of times. But the disadvantage is lack of adherence, overgeneralized advices are given, not personalized, non-therapist guidance, technical issues, and privacy concerns were raised. But looking at the public health concern and public health crisis with regard to insomnia and its effect, leading to benzodiazepine use, misuse, overuse, and abuse. Digital CBT-I is preferred over benzodiazepines. Now let's look into the various methods of delivering CBT-I. Again, a scientific reports published by Simon and his colleagues in Scientific Reports, they compared various CBT-I, how they have delivered. It is a systematic and network meta-analysis. They compared the CBT-I which was delivered either by individual onset, group delivered, group therapy, unguided bibliotherapy, guided bibliotherapy, unguided internet delivered, guided internet delivered, smartphone delivered, telehealth, sleep hygiene education, active contact control. So various methods were compared, and this was a network meta-analysis. These are the various method of delivery of CBT-I. They looked into that, and this chart clearly explained. In the bottom, you can say face-to-face had the maximum improvement. Next was telemedicine-based CBT-I was almost equivalent to face-to-face. The next third ranking was group therapy CBT-I, guided bibliotherapy. That means self-help book which was guided, smartphone-based, unguided internet-based CBT-I, guided internet-based CBT-I were both equally effective. Finally, the books were also used by them were effective. This study concluded face-to-face CBT-I is effective but hardly available because of access to psychotherapist is limited, not only in developing countries but also in developed countries. Waiting period somewhere between 3 to 6 months. In some places it is 1 year. Alternative to face-to-face cognitive behavioral therapy is internet-based cognitive behavioral therapy, telemedicine-based cognitive behavioral therapy, or else application or digital-based CBT-I. This internet-based CBT-I and guided bibliotherapy had medium to large effect size. But face-to-face, group therapy, telemedicine-based CBT-I, synchronous had the maximum effect size as per the study. If you look at the various applications, or you can see the platform Sleepy-Eye, Shruti, Sleep Rate, CBT-I Coach, Night Owl, and Mind District. But there are only 2 FDA approved applications, Sumerist and Sleep Rio Rex. But both have to be prescribed by the psychiatrist or sleep medicine physician. These 2. The rest of them can be downloaded on the apps or in this mobile phone. Now let's look into the effects of CBT on cosmia. Cosmia means comorbid insomnia and sleep apnea. If you look at the studies, insomnia and obstructive sleep apnea are comorbid. 30 to 40% of the people with insomnia have obstructive sleep apnea. 30 to 50% of people with obstructive sleep apnea have also comorbid insomnia. That means reverse comorbidity also is true. Invariably, you can consider 1/3 of them. Reverse comorbidity is true. In such a scenario, CBT-I has found to be effective in cosmia. This is a study Sweetman and his colleagues published in 2023 in Journal of Sleep Research. The title of the study is The Effective of Cognitive Behavioral Therapy for Insomnia, People with Comorbid Insomnia and Sleep Apnea, a Systematic Review and Meta-Analysis. This included 21 studies, 1,040 participants. This was a cosmia. COMSIA is the base. It is both comorbid sleep apnea and insomnia. Meta-analysis included 9 primary studies measuring insomnia severity index, indicating CBT-I is associated with larger improvement in insomnia severity. Subgroup analysis clearly indicated CBT-I is equally effective both in treated obstructive sleep apnea and also in untreated obstructive sleep apnea. Further, CBT-I improved when administered independently with PAP therapy and concurrent with PAP therapy, with or without even positive Airway pressure also, whether given or not CBT-I, improved the subjective measures on CBT-I. Now let's look into, considering the psychotherapists are very less, there are many guidelines came with regard to stepped care treatment of chronic insomnia. What does it mean? Stepped care means there are patients in the population who require less support and few patients require face-to-face therapy. Hence, it is called a stepped care treatment for chronic insomnia. If you look at the chronic insomnia population, self-help CBT-I, that is either book-based, manualized-based, or application-based, digital CBT-I can be given for larger population. They will do on their own. Many patients may not be tech savvy. In such cases, manualized self-help book can be helpful, and it can be considered. Group cognitive behavioral therapy is very useful. Even if it does not work, brief individual CBT-I, it can be 2 to 4 sessions. If further they do not improve, sleep clinic referral and face-to-face CBT-I up to 8 to 10 sessions can be given. This is how the stepped care model has been proposed for chronic insomnia where psychotherapists are less in number. In this regard, Savard and his colleagues published an article in 2021 in Sleep Journal. The title of the study was Efficacy of Stepped Care Approach to Deliver CBT for Insomnia in Cancer Patients. They compared both standard CBT-I versus stepped care CBT-I. The efficacy of stepped care CBT-I is not inferior to face-to-face CBT-I. That means by choosing either stepped care or standard CBT-I, both are equally effective based upon tailoring the needs of the clinical population. Hence, my dear friends, if there are psychotherapists are very less, stepped care CBT-I is the best choice rather than face-to-face. If you have many psychotherapists, please do consider face-to-face CBT-I. To conclude, my dear friends, CBT-I has 5 important components: stimulus control, time in bed or sleep restriction, relaxation training, sleep hygiene, and also cognitive therapy. These 5 components need to be used over a period of 6 to 8 sessions. Face-to-face therapy has found to be very effective, and subjective measures improved significantly, especially time to fall asleep, more time spent in a sleep, waking up less during sleep, and sleep efficiency has been found to be improved significantly. But however, objective measures on polysomnography or actigraphy was not significantly improved than subjective measures. However, app-based and internet-based CBT-I are found to be effective. Hence, this need to be utilized for exponential increase of availability of CBT-I. At this point of time, my dear friends, considering the dual public health risk, one is insomnia related and second one is benzodiazepine abuse related. To address both the public health crisis, task shifting and task sharing for CBT-I is the need of time. Hence, all nurses, primary care doctors, general physicians, social workers, all other allied healthcare professionals needs to be trained in cognitive behavioral therapy, and it is not very difficult. In a period of 3 to 4 days, you'll be able to learn cognitive behavioral therapy for insomnia. At the same time, you need to leverage technology, that is utilization of various internet-based CBT-I, using a hybrid method of both face-to-face, internet-based, and app-based is the need of the hour for treatment of chronic insomnia and to decrease the menace of benzodiazepine abuse in the population. This is about cognitive behavioral therapy for insomnia across the population. That should be the goal over a period of next 2 to 3 decades, my dear friends. Thank you very much for your valuable time. Stay safe.